Hi, my name is Kayla Brunswick, and we're going to be discussing prevention of postoperative ileus. So what is postoperative ileus? Basically, it's the impairment of bowel motility. Usually is the direct consequence of abdominal surgery. During abdominal surgery, the inflammatory response is activated because of a foreign object or manipulation of the bowel, causing leukocyte recruitment on the bowel wall. Leukocytes, or white blood cells, is another name for them. This causes suppression of the bowel muscle function. If an ileus lasts longer than about 5 days, it is known as a prolonged postoperative ileus. And based on this definition, 40% of patients undergoing laparoscopic surgery experience a prolonged postoperative ileus. Narcotic use for pain management is also believed to be one of the most significant factors causing postoperative ileus. Although it is necessary for patients to control their pain in the immediate post-op period, this seems to be something that is unavoidable, is the use of narcotic pain medication. So what is postoperative ileus? The highest occurrence of postoperative ileus is seen in procedures such as small or large bowel resections. The management of postoperative ileus in the United States was an estimate of $1.5 billion. So in one of the therapeutics and clinical risk management journals, they stated 350,000 colorectal and small bowel resections occurring annually at an average stay of almost 11 days at a bill to the healthcare system of greater than $20 billion. This study was prior to the one that we just talked about, with an estimate of $1.5 billion annually. But as you can see, these costs are very high, and this is something that we want to prevent, is the length of stay for patients with a postoperative ileus or with abdominal surgery in general. Postoperative ileus can occur in ages 18 and older. Patients over the age of 75 suffering from comorbidities such as diabetes, circulatory disorders, and chronic pulmonary diseases are at a higher risk of suffering from postoperative ileus, as well as other postoperative complications. So why is this teaching important to you? Postoperative ileus is a large contributing factor to prolonged hospital stays. You see a lot of, working on the surgical unit, over about half of the surgeries seen on this unit are gastrointestinal surgeries. So this is something that is seen, unfortunately, quite often. Postoperative ileus will slow a patient's recovery time. Also, this is important to inform you of the definition of a postoperative ileus, so you know what to look for and what to watch for. And teach you how to prevent postoperative ileus as a complication of surgery. And encourage you as patients to participate in the prevention measures to decrease chances of developing a postoperative ileus. Learning objectives for you as a patient. The patient will be able to identify what a postoperative ileus is. The patient will be able to identify the 3 most significant symptoms of a postoperative ileus. The patient will be able to identify the most effective postoperative activity in order to prevent a postoperative ileus. So postoperative ileus defined. We already briefly discussed this, but it is a delay in the return of normal bowel function after surgery. So it does have to be after surgery in order for it to be known as postoperative ileus. It's caused by the inability of the patient to pass flatus, or in other words, gas, and also the inability of the patient to have a bowel movement. So, question number 1. Postoperative ileus is when normal bowel function does not resume after surgery. A, true, or B, false? Correct answer is true. So again, bowel function does not resume post-operatively or after surgery. Signs and symptoms of a postoperative ileus. Nausea and vomiting occur because gas and fluids are not being absorbed by the body or passing through to the rectum, also causing abdominal distension. Abdominal distension can lead to further problems such as wound dehiscence, or in other words, where the surgical incision does not completely close. It begins to open up because there's nowhere for air or fluids to go. Pain is also a big sign of postoperative ileus. The inability to tolerate oral intake. And it is important to note that all of these symptoms together in conjunction would indicate a postoperative ileus. And usually we start to look for these symptoms about 2 days after surgery when bowel function has not resumed and the patient is starting to feel that nausea and vomiting and abdominal distension and pain. All of those together would lead to postoperative ileus. So question number 2. Which of the following is a sign or symptom of postoperative ileus? A, nausea and vomiting. B, abdominal distension. C, not able to tolerate oral intake. And D, all of the above. So the correct answer is D, all of the above. Rationale being that all 3 of these signs and symptoms in conjunction indicate postoperative ileus. So in order to prevent a postoperative ileus, although there have been some medications being trialed in the prevention of postoperative ileus, we're specifically going to focus on what you can do as patients to prevent this complication. The idea is that even if those medications do become available to patients, that you will still have to continue to perform these patient tasks, such as early ambulation or walking. This is beginning the day of surgery. Early food and fluid intake. This is not a lot of food and fluid, just enough to start to stimulate the bowel. And chewing gum, and all of those would occur starting the day of surgery. So early ambulation and the prevention of postoperative ileus. This is the most significant action you can perform after surgery in order to prevent not just a postoperative ileus, but also blood clots and pneumonia. Blood clots are prevented by encouraging that circulation, or continue to walking to pump that circulation through the body. And then pneumonia helps the patient take some deep breaths and open up those alveoli at the bottom of your lungs to prevent fluid from building up at the bottom, which is what causes pneumonia. It is also suggested that the day of surgery, patient should be out of bed for at least 2 hours. And this would include a short walk and then sitting in the chair. You could go back to bed after that. The 2 hours does not have to be consecutive. It just needs to total 2 hours that first day of surgery. The days after surgery, they suggest that the patient is out of bed for a minimum of 6 hours. And again, same thing, encouraging you to get up and sit in the chair 3 times a day for meals. And in between that, going for a short walk, even taking a shower is considered changing position and doing some sort of activity to get your body moving. So early oral intake and preventing postoperative ileus is still not something that's very commonly seen, but studies have been showing that early oral intake is tolerated in greater than 80% of patients. And it also has helped decrease postoperative ileus. So early feeding helps to assist the release of gastrointestinal hormones, which in turn creates peristalsis, or that gut motility, movement of your intestines to push food through. Gum chewing is another preventative measure for postoperative ileus. It elicits motility of the GI tract by increasing vagal stimulation or intestinal peristalsis. Kind of acts as a sham feeding to help promote gut motility. So sham feeding, or in other words, tricking the body into thinking it's eating by chewing on gum consistently, has been shown to be an inexpensive way to prevent postoperative ileus, and also a safe way to prevent postoperative ileus. You're not adding any kind of medication to your body. You're just trying to make your body think that you're eating. So this leads us to question number 3. Select all that apply. Identify measures that contribute to the prevention of postoperative ileus. A. Early ambulation. B. Brushing teeth. C. Chew gum. D. Early food or fluid intake. And E. Taking pain medication. So the correct answers would be A. Early ambulation, C. Chew gum, and D. Early food or fluid intake. So as discussed in the previous slides, all of these activities help to stimulate gut motility. So key points to take home from this presentation be how to identify a postoperative ileus by understanding the signs and symptoms, being able to define a postoperative ileus, and being able to identify preventative activities for the patient to perform. So any questions at this time regarding the presentation or postoperative ileus, or how you can go about implementing these measures? I've included a couple handouts for you. The first one talks about what is a postoperative ileus, the impairment of bowel motility after surgery. It also talks about some signs and symptoms to watch for. And then also how to know if this is an emergency. If you're unsure, it's always okay to contact your physician to get advice, or the physician's office. And if you haven't passed flatus or several days and are unable to keep any food or fluids down, and your abdomen is distended, this is definitely an emergency situation. The longer you're unable to take in food or fluids, the higher chance you have of becoming hydrated, which is definitely can lead to other symptoms.